Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of vulvar early invasive squamous cell carcinoma HPV-associated. So this is a case of a 65-year-old female patient who noticed a vulvar lesion that was excised. And as you can see here from the low power magnification, there appears to be full thickness dysplasia or atypia of the squamous epithelium. And if we zoom in into high power magnification, there is clearly the full thickness disarray of the squamous epithelium with the proliferation of those cells, the squamous cells that are dysplastic, showing similar appearance from the basal layer up till the very upper part of the squamous epithelium with basaloid nuclei, abundance of mitotic activity that would be consistent with carcinoma in situ. But I want really you to pay attention to the area here where we start to see some changes in the cytoplasm of the adjacent squamous epithelium. And more even clear here, this is the focus of carcinoma in situ or severe dysplasia or full thickness dysplasia. And then we see here the tongue that is extending to the subepithelial tissue. And if you notice something, the cells are becoming larger with more acidophilic cytoplasm and the start of keratinization. And another focus here, very clear. So here we have the carcinoma in situ, and then we have here the tongues that are extending from the overlying carcinoma in situ into the underlying subepithelial tissue with abundant, those cells showing are acidophilic in color. They are showing abundant acidophilic cytoplasm with vesicular nucleus and prominent nucleolus. And you start to see some edema into the surrounding stroma. And on high power magnification, I hope you can appreciate the difference in the size and appearance and color of the epithelium between the carcinoma in situ here and the early invasive tongue that is extending to the subepithelial tissue with more acidophilic cytoplasm and even dyskeratotic or abnormal keratinization, prominent nucleoli, and then the edema in the subepithelial tissue. And more so here as well, this tongue is extending separated almost completely from the overlying basophilic or more bluish colored carcinoma in situ to become more acidophilic, more pinkish in color with surrounded, and there is one cell here with the prominent nucleolus and then with the surrounded desmoplasia. Very useful tip to the identification of early invasive carcinoma. Now, once we have a suspicion of carcinoma in situ and or invasive carcinoma in the squamous epithelium of the vulva, we have to do mostly two stains. Number one is P53, and P53 beautifully highlights almost the lower 2/3 of the carcinoma in situ is strongly diffusely positive. And this is considered to be abnormal expression pattern that would really suggest or support the diagnosis of dysplasia. And here another focus. So the lower 2/3 show this very strong positivity that is really spanning the lower 2/3 of the epithelium. But what is really very important and very interesting was that those separated tongues with the acidophilic cytoplasm showed also this strong positivity, helping further to support the early invasive tongues or foci originating from but separated completely from the overlying carcinoma in situ. And on high power magnification, again, those tongues and even individual tumor cells are strongly positive for P53. So this is another way to support using P53 the presence of invasion. What was also really interesting is that P16 in this particular case, because we have always to assign an HPV association status to cervical as well as vulvar carcinoma, and we use the P16 immunohistochemistry as a surrogate marker for the HPV status. Remember that the usual staining pattern that is associated with HPV infection is the block positivity. However, recently description of null staining pattern for P16 has been rendered in cervical squamous cell carcinoma, for example, and this is a case of the vulva where there is complete loss of P16 positivity. There is no mosaic staining that would really be equal to a P16 positivity, the null staining pattern. So similar to P53, where we have the strong positivity staining abnormal expression or the null abnormal expression, P16, in addition to the block positivity staining pattern, now the null staining pattern is in P16 is becoming more and more recognized as a form of abnormal expression, and there is P16 again showing complete absence of the staining in the carcinoma in situ, but also in the invasive, small invasive fronts that are associated or that are the expression of the early invasive vulva carcinoma. Now, the final diagnosis that was rendered in this case is early invasive squamous cell carcinoma. The stage of this case is PT1A, FIGO 1A, because those invasive foci are 1 millimeter or less from the adjacent ridges from which they have originated. And remember that this is considered to be well-differentiated squamous cell carcinoma. The features of early invasion are those of what we call paradoxical maturation. The cells they acquire more abundant cytoplasm that is becoming acidophilic with the vesicular nucleus and prominent nucleolus. Now, the stroma in the background might show edema and or features of desmoplasia, but really the clue to the diagnosis of early invasion comes from what is very well known in the literature as a paradoxical maturation. There is, instead of seeing the same cells that are forming the carcinoma in situ invading, on the contrary, what we see invading are cells showing better cytoplasmic differentiation, larger in nucleus, more prominent in nucleolus. This is known as paradoxical maturation, a very useful sign to early invasive squamous cell carcinoma. I hope you find this tip useful in your daily practice. Thank you.